Our session here is on engaging and empowering patients for quality and safety. To introduce us, I'm going to give some brief opening remarks and then do my own talk. Then Michael Millinson, who I'll introduce in a moment, will give his, and then Dr. Is it Anisha? Anisha, thank you. I should have asked that before. I apologize. And then we'll have a closing panel at the end with some Q&A, which is where I hope things will get really useful. We have a small enough group of people here that if you have any questions of your own, you should be able to get them answered. It's my commitment that we tune this thing to be what you came for. As far as my own background, I gave one of the keynotes 2 years ago here, and I'll be referring to that in my talk. I'm a guy who is just a high-tech marketing geek, disruptive innovation, data analytics, and so on. And then in 2007, I found out I was almost dead of kidney cancer, and then I got better within 6 months. Pretty remarkable story. And then, as I'll describe, I discovered the e-patient movement and just started talking about it and blogging, and I wrote something that ended up on the front page of the Boston Globe, and my life ran out of control. Now this is what I do full time. And this year, 3.5 years into my little startup, it looks like my business is turning the corner, and I will actually reach break even. Boy, was that a fun thing to do. Michael Millinson will be our second speaker. He's the president of Health Quality Advisors. Those of you who've been following health quality for years surely know his name. He's the author of the outstanding book, Demanding Medical Excellence, which was first published in 1997, and as he said to me recently, I wish one word of it had changed since then. But for the most part, it hasn't. So our question here today, as a group, we're going to be presenting our thoughts, but what we need to get to is what can we do to actually move things, actually create change. He's been published in Health Affairs and many other places, and he's on several boards. And finally, Dr. Anisha is a newly named Executive Vice President of the Joslin Diabetes Center, certified physician executive in family practice, and a number of other affiliations, a very distinguished care. Now, Michael and I are going to be talking explicitly about the role of the patient. Dr. Anisha is going to be talking about an innovative program that Joslin is doing, which makes it easier for patients to engage with available technology through telemedicine. So I'll ask you to listen to her presentation, what they're doing for remote exams of diabetics' eyes in the context of the talks that go before that. And then finally, in our reaction panel at the end, we have the extraordinary fun of having Tom Peters join us when Mike Millinson mentioned to him the other day that he was coming here to do this. Tom actually asked if he could be here and join the panel. And so you can imagine he feels pretty strongly. He's been in many, many industries, and for those of you who are familiar with Plaintree, he knew Plaintree before it was Plaintree. The seed of it was just a little 12-bed unit in a hospital in San Francisco. And the important thing, in light of what I just said, is that he's got a record of working with leaders to actually accomplish change. So what I encourage you to listen to his brief thoughts at the start of our panel through that lens. Like, what can we do to actually move the needle better than the figures that the speakers this morning talked about? Now, I'm going to give my talk now to open the first speech part of this today. My title is, What if Dwayne Smith had a shared care plan? By show of hands, do any of you recognize the name Dwayne Smith? 2 people. Interestingly, both on the patient safety side of the equation. So when I spoke here 2 years ago, I got here and discovered that the opening speaker that day was Atul Gawande. And I thought, wow, this is interesting, because I was like new in my speaking career. So I listened to what he had to say. Before I launch into that, from Helen's talk this morning, I'm going to propose a taxonomy of fixes, of all the things she suggested that we could do differently. First of all, I suggest that there are some fixes that amount to putting more power in patients' hands in the form of information and tools. Then there are some fixes that have to do with listening to what patients report from the front line, because I think the big cultural disconnect here is that the people who've gone through the years and years of medical training, and I'm lucky. I mean, I'm somebody who was saved by great medicine. My median survival at diagnosis was 24 weeks, and yet 6 months later, my treatment had finished and I was all better. In the process, I broke my leg twice from a pathological fracture from the cancer, and yet I can just stand here on this repaired leg, and yet, so often we think if somebody doesn't have the training that enabled that, why bother listening to them? Because they don't have what made us smart. My point here is that patients are the ones who are on the front line. There's this thing you can buy in gift shops at the beach that said God couldn't be everywhere, so he invented grandmothers. Well, doctors and nurses can't be everywhere, but guess what? There's somebody who is there on the front line all the time. And then finally, there's a third category that I actually worded here as the problem, and that is not leveraging the available contributions. So I'm going to give you a couple of anecdotes, and I invite you to think back also to the cases Helen presented this morning, and think about this. What are the ways that there was an opportunity to achieve potential value, but it was squandered? Okay. Now, Michael Millicent's paper, just published in May, co-authored with the National Partnership for Women and Families, is very relevant to our regulatory climate here today. The engaged patient and the ACO, all right, the rules are changing on how people are going to get compensated. There are going to be new pressures to produce results. So I say, aside from what you might call the moral argument for patient engagement, to improve safety and quality, there is now, through these policy levers, there is now a financial argument for doing this. So there are new incentives for getting our act together. And I say our as a plural, because I do mean, as one questioner said before we started, this is not just about physicians doing better, it's about a more effective partnership. Really, I use this physical image of holding hands, but that's much better than two people on their own. So he says it's taken a full century for the patient's perspective to go from being routinely ignored to being hailed as a pillar of an ideal healthcare system. Rethinking the relationship between the patient and professional caregivers is a cornerstone of successful health system redesign. Consumer engagement in the exam room or in the boardroom is a central element. This is a really good paper. It's 23 pages, but most of it is white space on the pages, so it looks bulkier than it is. Really worth reading every word. That's a clever layout. I've seen whole books done that way. Now, but I'm going to add something to this, okay? I add the same for engagement at the bedside. As Helen pointed out, and many of you are probably familiar, bedside shift change catches a whole bunch of communication disconnects. All right, this is a central element of the redesign. Now, in Dr. Gawande's talk here, which I had the amazing experience of following 2 years ago, he recapped his keynote address at Stanford that summer, which he later published in The New Yorker. He told the story of Dwayne Smith, a grocery store manager who had a horrible head-on crash, spent 2 weeks in the ICU, amazing medical miracles. What Dr. Gawande does is he paints these contrasts. We do these wonderful things and then these ridiculously bad things happen. So here's this story. He was discharged in pretty good condition, 2 weeks in the ICU, and they put him all back together, except for one little thing. He'd lost his spleen because of all his blood loss, and when he was discharged, they forgot to give him the 3 vaccines that everyone is supposed to get to protect against common bacteria. He didn't know there was anything wrong. 2 years later, he was on vacation in Mexico, and he picked up one of these bugs. It ran through his body unchecked. They managed to save him again, but he lost all his fingers and toes. Now, what happened here? All right, let's think about this. First of all, it was a medical miracle, a great save, similar to my own. But then, an epic fail, as they say on Twitter and every other teen medium, Facebook, epic fail with great human cost. I don't know if you've ever known somebody who has no fingers or has no toes. You can't walk well. No, certainly no typing, no holding hands. It's a bitch to get dressed, It really is. It's not the same as death, but great human cost. And it was by the same people in the same system. So what's going on here? Well, when I followed Dr. Gawande 2 years ago, at one point in my talk, I ad-libbed, so what if Dwayne's family had Googled splenectomy? They're not physicians, but what if they'd stumbled across the fact on Wikipedia or somewhere that you're always supposed to get 3 vaccines, so that at discharge, even without any formal process, they might have said, wasn't he supposed to get some vaccines? Now, some people in some hospitals might say, oh yes, we're going to do that in a couple of minutes. Others might say, oh, holy crap, thank you so much. I don't care. My point is, this is the dynamic here. Information that's needed and has real value is being brought to the point where it's needed by somebody other than the provider. And I want to make really clear here, this is not about beating on providers. In fact, so here's what happened. Squandered potential value, an asset in the system. Knowledge that exists was not brought to the point of care at the time when it was needed. Now, who can solve this? What do? Do we pound on clinicians more? Anybody know clinicians who have excess capacity to take on more responsibility? It breaks my heart to see something like the pediatric nurse in Seattle last year who killed herself when she was hounded by the media after being personally involved in a baby's death. Think how bad she felt. She left behind 3 children of her own. What good did that do? Do we pound on clinicians more? No. As far as I can tell, clinicians work pretty much without a net. I gave a talk in Switzerland earlier this year where I held up the power cord to my computer and said, I can't plug this into your outlets here. The systems are designed so you can't do that. Some years ago, anesthesia was improved by relabeling the tanks and making it not, having the valves all turn in a consistent direction and so on. We need system improvements. Now, you go back to the job tomorrow, those fixes are not in place. What do? Well, Charlie Safran and Warner Slack at my hospital, Beth Israel Deaconess, have been saying since the 1970s, in the case of Dr. Slack, that the most underused resource is the patient. Now, granted, I don't have medical training. The patients in the bed generally don't have medical training, nor do their family members, but they sure are motivated. And if we don't do what we can to put power, tools, and information in their hands, we're missing an opportunity. Even better, what if the care team had shared the plan with the patient and family? Like, okay, here's what we're going to do, all right? We're going to give them a splenectomy, so just so you know, we'll do this and this and this and this, and then we'll give them 3 vaccines and so on. Now, sure, there may be some ways that's over the head of some patients and families, but for a whole lot of people in this room and out there, that's not over their head. And besides, if somebody doesn't want to, if they just want to say, look, you guys do your job, that's fine. I'm saying, why don't we leverage that commitment when we can? Well, I mentioned this in a workshop at the IHI Forum that December, and somebody at my table waved her hand and said, we do that. And it was Abington Memorial Hospital outside Philadelphia. Every day the EMR spits out a consumer language summary of the care plan. And I said, because I've worked with data a lot in my day job, I said, does a family ever notice mistakes in there? They said, all the time. Missing allergies, wrong medications. This is like the EMR version of bedside shift change, okay? Since we are moving toward more and more things being driven by the electronic medical record, data quality is essential. Data errors will become a more widely seen kind of harm. Why not engage patients and families in improving the quality of the medical record? Tom Ferguson, this visionary guy, who died in 2006, foresaw that with the internet, people would have access to information and each other in new ways, and he coined this term e-patient: equipped, engaged, empowered, and enabled. And in 2009, that group of people across the top formed the Society for Participatory Medicine, which I mentioned earlier. Now, I want to present a brief business analysis of what's going on here. This is from a colleague and friend at a university in Nijmegen in the Netherlands on the German border. He has this model that says that in Health 1.0, all knowledge existed above that dotted line across the middle is the membrane, if you will, between the institution and the consumer. And if you think in terms of ecosystems that perhaps might be built on algae as the fundamental nutrient, think of information here and imagine green dots above that dotted line. Now, what we're seeing today in the era of Health 2.0 is that sometimes patients are bringing value to the transaction. The circles are moving together. It didn't make me a surgeon or an oncologist or anything. And what they anticipate now is in Health 3.0 and beyond, whatever that means, we'll all be swimming in a common soup of information. And where this fails completely is if you cut off those lines because nobody's listening. All right, so that's what I propose. Tim O'Reilly, the great guru of the internet, said that Web 2.0 was when the web began to harness the intelligence of its users. The very early internet was read-only. People could publish a paper, publish a brochure, but there were no blogs, there was no writing things, nothing of the sort. And with Web 2.0, we could start creating stuff. Every time you write something on Facebook, that's Web 2.0. And now, to be sure, what O'Reilly didn't say here, it's when the web also began to harness the stupidity of its users. So you have comments like, "You are dumb," and "Take Laetrile, it'll fix your cancer," and things like that. The point is not here that everything you see online is great. I'm fond of saying in my speeches that I met my wife on the internet, but before I found her, I went through a lot of suboptimal search results. You know, you've got to learn to filter the gold from the garbage. And then finally, an economic argument. If the microscope is happy, and as we face crunch time financially, all right, all providers need to be thinking about this. When we put priorities on what treatments we keep and what things we cut back on, if the microscope is happy but the patient is not, has care been achieved? Care, not just health care, but care. Think about it in terms of your own family. Has optimal care, and in particular, was the money well spent for customer value? Customer value. Now, like what if, supposedly we have 3 times as many proton beam machines in Boston as all of New England needs. Now, what if a consumer council of some sort said, "You know what, you guys, I don't want anybody to spend another $7 million or $70 million or whatever it is on another proton beam machine. I'd rather have you funding better nutrition or community health programs or something like that." Who's going to say what value is? So engaging patients in better safety and quality is not just a matter of at the bedside. And this is a chart, as I wind to the end, from the Kaiser Family Foundation. The bottom 2 lines are wages and inflation. The top 2 lines are the cost of care. Nobody needs to come to Harvard to be told that costs are going up. But as a business thinker, okay, what strikes me is in what other industry do costs keep going up so far out of proportion to the consumer's experience of getting a better product? Can you find anybody who believes that their care is that much better than 12 years ago? But complaining about things doesn't get us anywhere. The interesting question is what's going on below that. And I think it's this. This is the only industry where the definition of quality doesn't start by asking customers what they think is important. You know, so here's a patient's definition of quality: achieving everything we can in care. That's good quality care, right? And yet, we have this famous paper from the Institute of Medicine in 2001. This is the source of the widely quoted statistic that on average, new medical knowledge spreads to half the doctors in 17 years. So if there's something that was invented 10 years ago, according to this, right, half the doctors today still aren't doing it. What if we gave consumers this knowledge about current best practices and standards of care? Here's what should be happening. This is stuff like diabetics. The doctor should take off their sock and look at the feet at every visit, right? And half of doctors in general aren't doing it 17 years afterwards. People call it compliance when a patient does what they're supposed to. I say, what the heck? Let's call it achievement. You know, compliance implies guilt and all that. I mean, whose goal is it anyway? Why are we doing all this stuff? Why do we have health insurance, right? And then, how are we going to define quality? Here's something from the New England Journal a year and a half ago. What I noticed in this is an article about EMRs, but I thought, this is like the bottom line here, patients whose care met 4 quality standards, only 51% in the best of cases here. What the heck is going on? And yet, when patients don't take their medication on schedule, it's called a compliance problem, but this was an article about quality. All right, what's going on with our paradigm here? Can we just wake up and realize maybe the problem, one of our new friends from Mars might come down and say, you know what? Patients do it half the time, doctors do it half the time. I think it's a human issue. Then we have a common grounds for moving forward. In fact, Peter Margolis at Cincinnati Children's said, you know, patients do it half the time, doctors do it half the time. We're only achieving a quarter of what we could. So my definition of safety is avoiding avoidable harm and mistakes, also known as accidents. Now, what could possibly stop patients, though, and I've heard this over and over again, what could possibly stop patients from speaking up to help? We are afraid of the doctors. We are afraid of retribution. I'm not kidding. All right, here is my buddy Hugo Campos, this amazing, he has an implanted cardioverter and defibrillator. He says it's great that the thing saves him when he has an episode, but he'd like to see the raw data stream coming out of it in real time so he can tell when he's heading toward an episode. How's that for an engaged patient, right? Well, Medtronic says, we don't see the business case in letting you do that. Well, and why doesn't he speak up more to doctors? Because he said, this is the front page of the San Francisco Chronicle, fear of being considered difficult and getting treated badly. We can do something about that. We can go back to our communities and say, guys, this is not what we were trained to do. So, in summary, the resource that's most often underutilized in our information systems are patients. And let me try to go back to one of my beginning slides. I think this is the taxonomy of ways that we can do this. Put more power in patients' hands with information and tools. Listen to what patients report from the front line, the bedside, the home, whatever. The woman who said, I want a dog. That's not a directly quality and safety issue, but listen. And then when we don't leverage the available contributions, it's a squandered opportunity. It's an economic inefficiency. Thanks so much. And now, Michael Millinson, I'll invite you up.